Good morning. On behalf of all of us here at the Cooper Institute, we welcome you to our Coffee with Cooper virtual series that focuses on taking control of your health and working towards a healthier future. This series presents up-to-date health and wellness information and offers suggestions for healthier living based on proven science. I'm Dr. Laura DeFina, President and CEO of the Cooper Institute. For those of you who aren't familiar with the Cooper Institute, Dr. Kenneth H. Cooper, the father of aerobics, established the Cooper Institute in 1970 to promote lifelong health and wellness through research, education, and advocacy. By improving public health, the Cooper Institute helps people lead better, longer lives now and well into the future. It is my pleasure today to welcome Dr. Camron Nelson, the President and Chief Executive Officer of the Cooper Clinic. Dr. Nelson received his Bachelor of Science from the University of Texas at Austin and his medical degree from the University of Texas Medical School in Houston. He completed his family practice residency and was chief resident at the University of Oklahoma, Tulsa Medical College. Dr. Nelson is certified by the American Board of Family Medicine. Today, Dr. Nelson is discussing the topic of diabetes and prediabetes, preventive strategies for a healthcare epidemic. We will have a few minutes at the end for him to answer questions you have submitted in advance. In addition, you can use the Q&A function on Zoom to ask questions during the lecture. We will get to as many questions as possible. It is now my honor to introduce Dr. Camron Nelson.
Good morning, Laura. Thanks for inviting me to speak on this important topic of diabetes and prediabetes. These both are epidemics that our country has dealt with and will continue to deal with. There's no doubt that every day we're all aware of the fact that diabetes is a growing epidemic. There are over 34 million Americans now that suffer from diabetes, and 88 million Americans have prediabetes, and we'll define that in just a minute. Diabetes is a major cause of heart disease, stroke, and the leading cause of death, and it's the seventh leading cause of death currently in the United States. Aside from the numbers of people with diabetes, this has a huge financial burden on this country. It's estimated that $237 billion is spent taking care of diabetics, and there's a $90 billion loss of productivity in our country related to diabetes and its complications. Now, while most of us don't have the problem like the middle screen here, we don't have that degree of being overweight. Truth is, when we step on the scale every morning, most of us are heavier than what we'd like to be or should be in order to prevent the development of prediabetes. In fact, 2/3 of us are either overweight or obese. This leads to 123 million of us are in that category, and only 1/3 are at healthy body weight. We'll define in just a minute. So if you look at the definition of being overweight or obese, we always use something called a body mass index. It's not difficult to calculate, but you have to get your calculator out. Generally, a BMI over 30 is considered obese, and a BMI over 25 is considered overweight. In general, this means that most of us, if you're carrying around up to 30 pounds extra, you're considered overweight. And more than 30 pounds extra is really defined as being obese. A rough feel in men, that generally means a waist circumference more than 40 inches, and in women, more than 35 inches is considered to be obese. A couple of graphs that illustrate this. This is a trend in obesity in the United States in the last 10 years. The darker colors indicate a higher percentage of diabetics. The highest color here would be magenta or red as we go through. So if you look at this is 2011, You fast forward then 4 years, 2015, if you look at the South, the southern states are then at this category more than 35% obese. You fast forward 5 more years. This is last year, 2020. It's pretty striking. If you look at the amount of obesity that spread throughout the country, including Texas, Oklahoma, Arkansas, Louisiana, this portion of the country, it looks pretty dramatic. It looks like from this, Colorado is doing pretty well. So here, another graph to show you the trend in diabetes. It's estimated in the next 10 years that we may be dealing with somewhere between 40 and 50% of Americans are clinically obese. The trend continues, and really we need to start to address this if we're going to make a dent in the number of diabetics in this country. Just as an aside, beside diabetes, obesity has complications that include cancers. You roughly can see here the cancers that have been associated with obesity. It's a large number. In fact, most common cancers have a diabetic or have an obesity connection. And in men, 14% of cancer deaths are related to obesity, and 20% of cancer deaths in women are directly related to being overweight or obese. So indeed, we have twin epidemics. The top trend line here shows the obesity trends over the last, this is over the last 30 years, and diabetes in the same length of time. And if you can see, the trend is there and continues to be there. The numbers are even worse between 2015 and 2020. So if you take those two parameters and put them together, these next 3 slides will illustrate obesity and diabetes trends. The green color, the darker green color, is the trend in obesity and diabetes. So there's 2004, 2010, and then in 2016, you can see the trend across the country in the twin epidemics of diabetes and obesity. So as you might know, there are 2 types of diabetes. Type 1 diabetes is related to generally a failure in your pancreas to produce insulin. In general, people with type 1 diabetes need to have injectable insulin. This only makes up about 5% of diabetics. So for the purposes of this conversation, when I talk about diabetes, I'm really talking about the 95% of the diabetic population that is type 2 diabetics. This is much more common and related to insulin resistance brought on by obesity and poor diet and lack of inactivity will bring on type 2 diabetes. It's entirely preventable and reversible if we deal with the lifestyle issues that bring this on. And I might add that the youth in our country are not spared from this epidemic. The trends in youth weight, obesity, and diabetes continue to rise. A short graph to show you the trends. If you look at type 2 diabetes, it's increasing at a significantly higher rate in the youth than type 1 diabetes over the last 20 years, basically. So again, the weight issue with youth, inactivity, the poor diet is certainly contributing to the incidence of diabetes in the youth. And I'd like to just give a shout out to the Cooper Institute for helping to stem the tide with this youth epidemic through their FitnessGram and NFL Play 60 programs. If you don't know about these programs, I'd encourage you to go to the Cooper Institute website and look at how these very innovative programs have made a difference in the youth trend in poor health and inactivity. So let's define diabetes and prediabetes. So there's 2 ways to look at this. You can look at a fasting blood sugar, and in general, a fasting blood sugar below 100, and this is an 8 to 12 hour fast. A fasting blood sugar less than 100 is considered normal. Between 100 and 125 roughly is considered prediabetes, and diabetics with a fasting blood sugar that's reproducible higher than 126 is considered diabetic. An easier way to look at this is using something called hemoglobin A1C. It's an innovative way that's been available for the last 25 years to look at an average blood sugar over a 90-day time frame. So a hemoglobin A1C of below 5.7% is considered normal, whereas A1C between 5.7 and 6.4% is considered pre-diabetic, and above 6.5% is considered diabetic. The endocrinologist will use that A1C number to adjust medication regimens for people that are diabetic and adjust insulin doses and other medications. So really what we want to concentrate on is trying to diagnose and to treat through lifestyle modification the people, those of us that are pre-diabetic. So most of us really need to know our numbers. Just like you know your blood pressure numbers, your weight, your pulse, your cholesterol numbers, we all need to know what our diabetic numbers are. It turns out that there's 88 million people, as I mentioned, that are pre-diabetic. That's 1 in 3 of our population is pre-diabetic. And the striking thing is that 80% of those folks that are pre-diabetic don't know it. They haven't been tested. They haven't engaged with their physicians to know that they have hemoglobin A1Cs above 5.7%. So again, this just speaks to knowing your numbers, because you can't take action if you don't know that the whole process exists in your situation. So the CDC and the American Ad Council has a clever campaign to draw attention to this pre-diabetic condition. It asks the question, are you pre-diabetic, or could it be your co-pilot or your co-pilot's co-pilot? So literally, 1 in 3 people is pre-diabetic, which I find fascinating. And I can tell you in clinical practice, that's exactly what we see. And it's almost always related back to weight issues. So the CDC and the American Ad Council also have a little test that you can take. It's a 6-question test that kind of gives you a sense as to whether you're in that pre-diabetic category. This is available at their website, but I'd really encourage everybody to know their hemoglobin A1C number, as that's going to be the most accurate read of pre-diabetes. Pre-diabetes, almost 50% of the time, goes on to develop diabetes. And so it's an important next step at preventing diabetic and all the complications thereof. And we'll talk about complications of diabetes in just a minute. So by losing weight, eating correctly, you'll cut your risk of developing diabetes by 50%. Diabetes is a multifactorial illness we'll talk about in just a second, but heart disease, stroke, many other things are complications of diabetes. Study done by the CDC and published in New England Journal of Medicine several years ago shows indeed by losing 5 to 7% of your body weight, which is not a huge amount. It takes a consistent effort at diet and exercise to achieve that, but you'll cut your risk of diabetes by 58%. That's a similar number to what we find with exercise. We'll see a little bit out of the landmark study with the Cooper Institute. So metabolic syndrome is a very dangerous syndrome, which includes abnormal blood sugars. Let me run through the criteria for metabolic syndrome. It's a fasting blood sugar over 100, as we talked earlier. Obesity is defined by waist circumference in males over 40 inches and females over 35 inches. And LDL cholesterol, that's the HDL cholesterol, that's the good cholesterol of less than 50 in females and less than 40 in males, is part of the metabolic syndrome. High triglycerides over 150 qualifies for metabolic syndrome in this constellation of findings. High blood pressure with the blood pressure over 130, over 85. And this all leads to insulin resistance, which dramatically increases your risk of cardiovascular disease, stroke, and the other complications of diabetes. Risk factors for diabetes obviously include excessive weight. It turns out that high blood pressure, elevated cholesterol, and family history of diabetes also contribute to your risk of being diabetic or pre-diabetic. It's also noted that women with gestational diabetes, that's abnormal blood sugar during pregnancy, also increases your risk of developing diabetes later in life. And people over the age of 45, largely due to weight issues, are at increased risk of developing diabetes and prediabetes. Just a word about artificial sweeteners. I think there were some questions given prior to the talk here today about artificial sweeteners cause diabetes. It turns out that artificial sweeteners can actually trick the pancreas into secreting more insulin than what we would normally have. And insulin is a pro-inflammatory compound. So the answer is many sweeteners can indeed increase the dysfunction with the pancreas. It's probably a little bit of a reach to say causes diabetes because there's so many other factors. But I think most of the authorities will say that artificial sweeteners may be contributory to this in some individuals. There's a question mark about stevia, which is the more natural artificial sweetener. The data is not completely in, but a conference that I was at a month ago mentioned that stevia may be the least complicating of all the artificial sweeteners. Just another word about diabetes and ethnic background and race. It turns out that American Indians and Alaskan Natives have about a 15% lifetime risk of developing diabetes. Hispanics, 12.5%, non-Hispanic Blacks at about 12%, Asian Americans at 9%, and non-Hispanic whites are at about 7.5%. So there's definitely a ethnic predisposition to diabetes. So as I mentioned, diabetes is a multifactorial illness that causes inflammation. People end up with cardiovascular disease at a risk that's 2 to 4 times average of people that are not diabetic, can cause nerve damage, blindness, and renal failure as well. So just again, to illustrate how multifactorial this is, the incidence of heart attacks and pre-heart attacks are much higher in people that are diabetic. Stroke risk is higher. What's called peripheral vascular disease, which is the blood vessels in your legs and feet, is a much higher incidence in people that are diabetic. So you'll find people that are diabetic losing limbs, feet, toes, and even legs to diabetes. People develop what's called diabetic retinopathy, which is a retinal problem, as well as kidney damage and glaucoma. Diabetes affects small blood vessels. And so the commonality with all these organ systems is small blood vessels. So small blood vessels in the brain, in the heart, in the feet, in the eyes, in the kidneys. These tiny blood vessels succumb to what's called atherosclerosis, which is advanced by poor blood sugar control and diabetes. So heart disease and diabetes is the big one. As I mentioned, heart attack risks are 2 to 4 times in diabetics what there are in non-diabetics. If you look at the risk of heart disease, as a species, 50% of us as humans die of heart disease or stroke. That's just the way that it is. This risk is dramatically increased in people that are diabetic. And in fact, it's been said that the risk of a heart attack in a diabetic is the same as the risk, the risk of a heart attack in a diabetic is the same as the risk of somebody that's already had heart disease, already had a heart attack that's not diabetic. So a non-diabetic heart attack conveys the same risk of a subsequent heart attack as people that are diabetic that have not had a heart attack to that point. So this is a graphic that shows what happens to blood vessels. And this happens to be a blood vessel in the heart. Any blood vessel is going to react the same. Diabetes is inflammatory, which means that it causes stickiness in the blood vessels, in the brain, in the heart, and in the kidneys. When it does that, cholesterol begins to build up and stick, ultimately leading to blockage and blood clots in those organs. And so the end organ damage is related to inflammation, which causes cholesterol buildup. Just a brief word about diabetes and COVID-19. Again, diabetes is an inflammatory illness, and so is COVID-19. COVID-19 is a very intense inflammatory virus, which is the reason we have so many, a myriad of complications from COVID-19, including pneumonia, including blood clots, including stroke, including kidney damage. So diabetes is one of the illnesses that can increase your risk of going to the hospital with COVID-19 by 6 times and increases your risk of death by 12 times over those folks that do not have these comorbid conditions. So the mainstay of treatment for diabetes and prediabetes is lifestyle management. Just a word about metformin and prediabetes. It can be considered in people that are pre-diabetic as an adjunct to lifestyle changes, but to do metformin without lifestyle change is probably not a wise thing. Metformin would be used especially in people that have elevated fasting blood sugars with or without elevated hemoglobin A1C, those with an excessive body mass index. You want to keep metformin generally for people less than 60. There are complications with metformin you have to watch closely, including kidney damage, and some people develop gastrointestinal side effects, including diarrhea on metformin. If women have a history of gestational diabetes, that's another indication for potentially considering metformin for treatment. Even though it's a good medication and probably underutilized, it's not the mainstay in the treatment of diabetes or prediabetes. So back to basics, a healthy diet is the mainstay of the treatment of many illnesses, including diabetes and prediabetes. In general, when we talk to the dietitians, if most of us can stick to something like a Mediterranean diet, we would all benefit. So with the Mediterranean diet, it would emphasize vegetables, fruits, whole grains, beans, and legumes, and limit sugars. And so sugared soft drinks, plain sugars, highly processed foods, carbohydrates that are refined, as well as saturated fats and processed meats would be things to limit in your diet. We'd also want to encourage fish and chicken over red meat, and non-tropical vegetable oils and nuts would be a positive part of the Mediterranean diet. This encourages better insulin control in each one of us, and it also can help with weight loss. Also, I want to just briefly mention portion sizes. As most of us know, portion sizes in our country are way out of hand. A good segue, a hand is a good way to remember what needs to be on your plate. A palm full of protein, be it chicken, fish, or lean red meat, would be the right portion size for protein. A fistful of vegetables is a mainstay on your plate. You want to limit fats to no more than 1 thumbful, if you can imagine that, and limit your carbs to a cupped hand would be the way to measure that. So pastas, breads, potatoes, starches need to be somewhat limited compared to lean protein and vegetables. Just a word about healthy eating and sleep. It turns out that poor sleep is going to fuel bad habits and increase your inappropriate snacking. So I'd encourage everybody to work on sleep patterns. We all need to get 7 to 8 hours of sleep per night, and your body's going to work more efficiently in all regards. But certainly, diet and weight are tied to poor sleep habits. So many of you know the landmark study that was published by the Cooper Institute in 1989 addressed the whole issue of activity, and moderate exercise is extremely important in the maintenance of good health, including limiting the effects of diabetes and prediabetes. In that study, with 10,000 person years were evaluated and age adjusted. So people in a very poor category of fitness, poor category, fair category, and excellent category of fitness were evaluated. It turns out that moving from a sedentary, very poor category of fitness into a fair category will dramatically decrease your risk of all-cause mortality, and in essence, it decreases your all-cause mortality by 58%. Huge study, changed the course of medicine, changed the course of what we prescribe as physicians in terms of activity level. It also turns out that 58% decline in all-cause mortality is attainable for each one of us. It means that we need to strive for 150 aggregate minutes of exercise a week, and it can be moderate exercise. It doesn't have to be marathon or excessive exercise. You can gain a small bit of extra benefit by being in a good, excellent, superior category of fitness, but it's not mandatory. Moving from a sedentary lifestyle to a moderately active lifestyle has huge implications for your weight and overall health. This was revisited by the Cooper Institute with the study that was published last year, where they followed 48,000 men for over 50 years. And this reiterated and reconfirmed the benefit of moderate exercise throughout a life. The groups that were followed between 1970 and 1991 showed a 47% drop in all-cause mortality in highly fit individuals and a 40% drop in those with moderate levels of fitness. In the broader group that was followed on through to 2014, you can see similar drops in all-cause mortality with moderate fitness. So if you look at the dangers of being sedentary, they're so multifactorial. As I mentioned, cancer risk goes up, blood pressure, cholesterol go the wrong way, obesity, type 2 diabetes trends in the wrong direction. You develop sleep problems, quality of life begins to suffer as well with a sedentary lifestyle. So less quality of life and less quantity of life. People live on the average of 7 to 8 years less, and certainly people have a lower quality of life with a sedentary lifestyle. Dr. Cooper has always talked about squaring off the curve. If you look at people that do not pay attention to their overall activity levels and strive to be non-sedentary, they tend to have a lower quality of life. They tend to burn out. They tend to die earlier, and their quality of life is much less. If you stay cognizant about moderate activity, people live longer and they have a much higher quality of life till the end. So the idea is you want to live and die in about 2 seconds best you can. That's not always attainable, but that's what we need to all strive for. At the physician's office, he's told his patient what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day. That's an overstatement, but it's very true. All of us would benefit greatly from trying to achieve that 30 minutes of moderate exercise 3 to 5 times a week. One of Dr. Cooper's famous quotes is, "It's easier and more cost-effective to maintain good health than it is to regain it once it's lost." It's so true, and Dr. Cooper is an excellent example of this. He continues to be very active at the clinic, the Institute, and all his speaking and writing endeavors as well. Another analogy that I like is that it's much easier to keep Humpty Dumpty from falling off the wall than it is to try to put this mess together after he's hit the floor. In fact, it's often impossible to reassemble all these parts, all these things that wear out in each one of us after we neglect our health. For many of us that have neglected or at a season in life where we've fallen away from regular exercise, diet, it's kind of discouraging. General Patton has said the less than perfect plan applied today with vigor is better than a perfect plan applied at a later date. So it's not too late to start. Each one of us needs to re-engage and start that today. The worst enemy of good is perfect. We just need to kind of pick up where we are and move ahead. It's been said that exercise could be packed, if it could be packed in a pill, it would be the single most widely prescribed and beneficial medication in our nation. I think as an American public, we all are looking for a treatment in a pill. It's not there. And medication is meant to be an adjunct, but not an answer to the problem. It's also been said, exercise is medicine, and it's so true that if we can just all commit to moderate exercise, not out of the ballpark exercise, if we can all be consistent with that, it's going to have more benefit than any medication I can prescribe. An old Chinese saying says, if we don't change our direction, we'll surely end up where we're going, and there's no truer statement than that. So we got some questions earlier about resources. Cooper offers several. The Cooper Aerobics website and the Cooper Institute website have great resources on how to jumpstart your new lifestyle and continue your journey toward overall health and wellness. The Cooper Cooper Wellness Strategies also offers Cooper Tracks. Again, on their website, there's lots of availability of things, including diabetic thoughts and processes as well. So in closing, the Bible says that we should all be encouraged and have a cheerful heart and not end up like this fellow in this picture. We don't want to end up bones before it's our time. And so I would say that Scripture also says that laughter is good medicine, and I think that's such a true statement. Don't get discouraged. Pick it up where you are now and commit to a good, healthy lifestyle. And indeed, the risk of diabetes, prediabetes will drop dramatically, and you'll live a longer and healthier life.
Thank you, Cam. That was an excellent overview of prediabetes. I so appreciate that you shared that with us. Now it's time for some questions from the audience. And the first question, actually, you've already touched on a couple times, but I want to just sort of focus on what's the first step? So to your point, you don't have to go from nothing to everything. But if people want to begin, what exercise do you recommend to begin with? And I think a lot of us get frustrated if we can't go from, 0 to everything immediately. But what exercises do you recommend when people are starting? And if you had to pick a first dietary change to make, what would it be?
Laura, that's a real common question. There are modifiers to that. I will tell you that people that are dealing with being overweight or obese, you definitely don't want to start an exercise program that increases your impact on your joints, such as knees and back. And so if exercise has not been part of your regimen, simple walking is a good place to start. And I'm more concerned about the consistency of exercise than I am the intensity to begin with. And so if you can commit to 30 minutes, even 20 minutes, if you've not been doing anything, 3 to 5 times a week, the yield in weight loss is going to come at about 5 times a week for 30 minutes. If you can work up to that and increase your heart rate when you exercise, there's parameters for that. We can go through at a different time, but just if we can get all of us to be consistent with their exercise for 30 minutes, 3 to 5 times a week. Ultimately, a non-impact activity would be a treadmill without running on it, with a little bit of an incline is a great way at home in inclement weather, people up north, to get your exercise piece. People enjoy spin cycles, Peloton, or Nordic Track. Exercise is a good way also to get that in without impairing your joints. People enjoy jogging, but I can tell you out of experience, at some point, people need to transition from a high impact activity like jogging into one of the other activities. As far as diet goes, portion size is a instrumental way to cut calories and to limit your bad effects of calories and weight. In general, excessive carbohydrates, particularly processed foods, breads, we need more complex carbohydrates. And so simple carbs are going to be an easy way to jumpstart your diet. Add more fruits and vegetables and add more fiber is a great way to think about diet. That's largely what the Mediterranean diet is about.
Excellent. And I think one of the things that people get frustrated by is the fact that they think they have to be, from where they are to everything. And your point is so well taken. You've got to do it gradually, and you've got to do it as it fits your body habitus. So one thing I wanted to ask was the natural sugars. So we want to eat more fruit, but there's sugar in fruit. So am I going to make my diabetes risk worse?
Actually not. The fruits, including berries, actually, it has fructose, but it's better processed than sugars from other sources. So you surely wouldn't want to have natural sugars, fruits being the mainstay of your diet, but as part of a bigger diet, certainly with berries in particular, there's not a problem with fruits. The thing I would tell you to avoid is fruit juices. If you look at orange juice, you're not getting the fiber content with the fruit, and you're getting a high load of sugar. So fruit juices are probably something to avoid, as would any sugary soft drink or a source of sugar otherwise. So in general, fruits are part of the bigger picture and would be just fine with a diabetic diet.
Excellent. Another question from our audience is, what's the benefit of intermittent fasting with the prevention of diabetes?
So intermittent fasting, if done correctly, is fine. You just don't want to necessarily be legalistic or dogmatic about it. For instance, if your intermittent fasting is not eating after 6 o'clock at night, and your 12-hour fast is between 6 p.m. and 6 a.m., that's quite helpful. Most of us need to limit our calorie intake in the evenings as well. So you could go 7 to 7, depending on what your schedule is. So that would be a form of intermittent fasting. That 12 hours of not eating, it just happens to be the time of day that you would rather not eat anything. So as part of a bigger picture, not a problem with that, but you don't want to get dogmatic about it and leave your body high and dry and suffer from hypoglycemia. That would be contradictory.
Excellent. Another question from our audience is about actually the hemoglobin A1C test. And I guess question number one with hemoglobin A1C is you need to get that from the doctor. And is it the standard for making the diagnosis? Since there is such great variability in fasting blood glucose if you had a bad cupcake day the day before. So do we have to go to our doctor to get it? And do you agree that it is more reliable and something that we should all look at over fasting blood glucose only?
Yeah, it's a good point. I need to thank whoever the lab person was 25 years ago that figured out hemoglobin A1C, because it really did revolutionize our ability to hone in on people that are diabetic or pre-diabetic. So it's a way to do a 90-day average, all comers over the last 90 days, before meals, after meals. And there are direct standards as to what that should be, and that below 5.7% is a well-established standard for establishing the diagnosis of pre-diabetes. Fasting blood sugars, you're correct, Laura, would be all over the board. It's not a reliable source. There's something called a glucose tolerance test, which requires a 2-hour set of blood draws, which has always been the gold standard, but it's logistically very difficult to do. So the hemoglobin A1C has really turned into the gold standard for diagnosing and for the treatment of diabetes as well. Unfortunately, this is a physician blood draw type of a thing. Just like your cholesterol check would be something that you ought to do periodically. I would tell people at least once a year, just like you'd have your cholesterol rechecked. You need to include in that a hemoglobin A1C, because it's so illustrative of risk when it comes to diabetes or pre-diabetes.
Superb. So another question is about a particular thing that I've read about in the literature, and one of our listeners has asked about, is apple cider vinegar and its impact on risk.
It's interesting. My feeling is apple cider vinegar is somewhat of majoring on a minor. It's not a key feature and prevention of disease. So the data is variable and changes over the course of time. I'm not overly impressed that apple cider vinegar is part of a bigger solution, though.
Very good. So I was glad that you presented the information about the risk in COVID, because I think people who do have high blood sugar and diabetes certainly need to be extra careful. Does controlling the blood sugar in that setting decrease those terribly increased risks of COVID? And is there anything else people with prediabetes and diabetes should do to avoid terrible COVID?
Yeah, if you back up and realize that diabetes and prediabetes is not a point in time, it's a long-term health issue. So I would say that controlling blood sugar will have some impact on how you do with COVID. People that were walking into the hospital with a blood sugar of 350, obviously they had their own challenges beside COVID. Better diabetic control or pre-diabetic control in general, which is a lifestyle, does have an impact. I'm not sure that I can tell you that a blood sugar of 100 does better than a blood sugar of 130. I'm not sure that necessarily is a predictive factor. It's the whole issue of insulin resistance that conveys the inflammatory process with prediabetes and diabetes. Of course, better blood sugar control, avoiding prediabetes is going to help. I don't know that it's going to make a difference in the near term. The take-home message is, if you're diabetic or pre-diabetic, you need to be overly cautious about contracting COVID. And if you do test positive for COVID, you need to be watched a little more closely than somebody that was not pre-diabetic.
Very good, thank you. So I think to bring it all together, the risk for pre-diabetes and hence diabetes in the United States has gone up in the last 20 years, as you noted. Early markers for potential future diabetes that people should be watching for, just to restate that, because I think it is so important with the obesity epidemic and the follow-on diabetes epidemic. What would the things we want to have as takeaways for our audience be?
As I mentioned, prediabetes is largely asymptomatic. Remember that 8 in 10 people that have prediabetes have no symptoms whatsoever. The thing that needs to make you think about prediabetes is your waistline. So if you've got a larger waistline, if you're overweight, particularly more than 5 to 10 pounds, you ought to be thinking about, how is my insulin doing? And in fact, I think if we could dive down into the cellular level, people, even with an extra 10 pounds, their insulin system is struggling, trying to keep up. The way I like to think about it is your pancreas only makes so much insulin, and it can only cover so many pounds of body weight. It's more complex than that, but basically, the more weight you're carrying, the more difficulty your pancreas is going to have in trying to deal with that. So the take-home message is, if you're carrying around extra weight, you ought to be cognizant of whether or not you're pre-diabetic, and you ought to have that checked on a blood draw the next time you're at the doctor. It'll be eye-opening to see hemoglobin A1Cs in the 5.9, 6.0%, which means people are fully pre-diabetic and all the associated risk that goes along with that.
Well, thank you so much, Dr. Nelson. That was a very interesting and excellent presentation about prediabetes and diabetes. We're really grateful for the support of the Cooper Clinic. For our audience, please check out our website at thecooperinstitute.org for upcoming Coffee with Cooper sessions. Thank you all for joining us. Thank you, Dr. Nelson and your team. And everybody have a great day. Get your exercise and eat right. Thank you.
It's a pleasure. Thank you, Laura. Here.